Next, Magnus Ohman and Dr. Ralph Brindis, professor of medicine at UCSF and senior advisor for cardiovascular disease for Northern California Kaiser, as well as the immediate past president of the American College of Cardiology, discuss appropriate use of PCI in stable coronary artery disease.
Welcome to ACCEL, Ralph.
It's a thrill to be here with you, Magnus.
So appropriateness criteria has really sort of stormed our world here in the last 2 years, and they're becoming online. We'll be able to feed the information back to our clinicians. But I think there's a general sort of tension here is what is appropriate and what is maybe the corollary not appropriate, and what do we know about this in stable coronary disease?
Well, it's a fantastic subject for us to take on today. You know, cardiovascular specialists are totally under attack. We represent 43% of Medicare expenses, cardiovascular disease. We hear all about inappropriate angioplasty, not just in the state of Maryland, but even on the Dr. Oz show, who claims that 50% of all angioplasty in the United States is inappropriate. In fact, Elliot Fisher was on Katie Couric a year ago claiming that 30 to 40% of PCI is inappropriate. And this, of course, is just not true. You know, we've learned a lot through the National Cardiovascular Data Registry. We're actually measuring appropriateness in PCI. And we've done this through the utilization of the appropriate use criteria for coronary revascularization published by the college 2 years ago, looking at typically 5 domains and how interventional cardiologists think in terms of assessing whether a patient should be a suitable candidate for angioplasty. We, through the NCDR, having those domains being able to be measured, such as how the patient presents, the degree of symptoms, the amount of ischemia, non-invasive testing, the medications that they're on, and of course the disease burden that we find on coronary angiography, can really determine whether it's appropriate, inappropriate, and uncertain for angioplasty. Now, one of the concerns, Magnus, and I want to be upfront with this, is people are kind of confused. What's the difference between clinical practice guidelines and appropriateness? And I want to assure you that the appropriate use criteria algorithms, if you will, I call them derivative products from our clinical practice guidelines. In fact, when we did matching, we found there was absolutely zero discordance between what our clinical practice guidelines say related to revascularization and appropriate use criteria in terms of the class 1s and the class 3s. Important point.
I'm glad you brought that up because obviously guidelines, I think many physicians realize that if they follow the guideline for certain conditions such as ACS, the outcomes actually track. That is to say, they're better outcomes. So I'm glad to hear that piece. The other part, which I'm glad you also brought up, is the fact that we're not talking about appropriate use of cardiac catheterization because, as you pointed out, we're talking about anatomical issues. How do we bring this out to the community and say it's not about not cathing, it's about defining the risk with all these domains that you brought up?
What's particularly fascinating, what's going on in the NCDR, is that just this past quarter was the first time that hospitals have received benchmark reports related to appropriate, something that we should be quite proud of our professional society in taking on. No other professional society actually has put together criteria like this, measures it, and feeds it back to our clinicians. Because it's only in that way that our clinicians can actually understand their practice patterns. We really have not done that at all in the past.
So tell us, how are we doing on a national level? How appropriate are we? We're pretty appropriate?
Well, there's always room for improvement, but I actually view that the paper that was produced with the lead author, Paul Chan, in JAMA this past summer, as an incredible piece of advocacy for the interventional community. They looked at the last 500,000 angioplasties performed in the United States in the period from 2009 and 2010 and found that only 4% were inappropriate, a lot different than what Dr. Oz and Elliot Fisher said on the Katie Couric show. However, just like you said, if you looked at the acute indications, needless to say, they were almost all appropriate, about 99%. The opportunity to improve is the area that we're here to talk about today, that is stable angina, where 50% were found to be appropriate, 35% found to be uncertain, with about 12% inappropriate based on our criteria. This is the area that we have opportunities for improvement.
So give us some idea on how we can do better as physicians, because I come from the school that I think at heart most physicians really try to do the right things. Is part of this lack of our documentation for challenges, or what do you see the pieces here that are missing for us to sort of better understand this?
First of all, I think you're correct. I view this as not a performance measure yet, appropriate use criteria. I view it as a test metric. We need to understand, first of all, if the data is accurate. I think that there'll be improvement in how the hospitals and physicians actually enter the data related to appropriateness as we learn over time. But there are opportunities of improvement. One of the other very interesting aspects of that particular article of Paul Chan was the marked hospital variation related to appropriateness. There were some hospitals that were, quote, performing inappropriate angioplasty in the setting of stable angina in the 0 to 4% range, but some were as high at 40%. The right answer is not to be 100% appropriate. How we react to a given patient, 100% is not the right answer. But there shouldn't be such a marked variation. There are opportunities for improvement. One of the interesting things maybe our audience would be fascinated by is, well, what were the typical indications that were found to be inappropriate present in this? The most common one, and I'd be interested in our audience how they felt about it, was in patients who had either single or double vessel disease without LAD involvement, no prior bypass surgery, who had minimal symptoms, had a low-risk stress test, and were on no medication. Do you find those patients should have angioplasty, or shouldn't we try medical therapy?
Most of us would agree, put them on medical therapy, and I think that that's the right approach. It helps us to discuss it and put those in the right place. I totally agree. But I would also argue maybe the doctors actually didn't stress enough that the patients were allergic to issues. Maybe they had gone through drug tests, but when they were checked into the NCDR, they didn't really have all their medications documented. So I think this goes to my thinking is that now that we're in this new era, we need to document better why we do certain things. And I think that's a terrific advantage that we can move forward with this.
I totally agree with that particular comment. One of the fascinating things is, of course, this is all retrospective. Wouldn't it be terrific if we can actually have a tool ahead of time to help guide clinicians in terms of their decision-making about going forward, or even having the data to advise the patients and the family about treatment options that would be more appropriate or inappropriate or maybe uncertain?
I think the other part to this, we always have to be careful because our patients' wishes needs to play into this, which I think is an important part. Patients' wishes and the flexibility, and you already said it, 100% appropriate or 100% inappropriate is not the right answer. The right answer is some flexibility around healthcare, around patient satisfaction.
We have a lot to learn in terms of how to better educate patients. As you know, there have been a couple of studies that 3/4 of all patients in the setting of having angioplasty for stable angina thinks it prevents MI, and 3/4 thinks it makes them live longer. So we have a lot of education to do.
Well, I'm really glad we got to hear this discussion about the appropriateness criteria and how they played out in stable coronary disease. I think it's very important for all of us to be aware of it. As you said, we have more to learn.
Thank you so much, Magnus.